Welcome everyone to this month's session of the Grand Rounds for the Australasian Metabolic Health Society. Tonight we have the pleasure of being taught by one of our low-carb luminaries in Australia here that many of you will know, Dr. Paul Mason. Dr. Paul Mason is a fellowship-trained sports and exercise medicine physician with degrees in medicine, physiotherapy and occupational health. He has significant expertise in medical nutrition therapy, especially with respect to low-carb, ketogenic, Paleolithic and carnivore diets. He regularly lectures on nutrition both in Australia and internationally, and as a sports medicine physician, he also consults with many athletes and professional sports teams. And today he's going to be talking to us about insulin resistance.
So that I can be able to deliver it to family.
Awesome. Well, thank you for that, Alex. I'm glad that it's not just me who's got the noisy family. Hopefully you can't hear that in the background. All right. So today I wanted to talk about insulin resistance. Now, this has been something of a bit of a journey for me, mainly because what I've considered about insulin resistance in the past has been blatantly incorrect. And when I do finally do some formal lectures on this with slides, I'm contemplating actually getting some video clips of my previous lectures where I talk about insulin resistance just to prove how badly I got it wrong. But notwithstanding, insulin resistance is actually the single most significant cause for almost all chronic disease today. And there's a long laundry list of them: type 2 diabetes, coronary heart disease, stroke, hypertension, cancer, dementia, Parkinson's disease, polycystic ovarian syndrome. You know, the list is long. So obviously, if we can develop an effective treatment for insulin resistance, and that doesn't necessarily have to be pharmacological, that could be nutritional, then the gains, the benefits, the potential benefits are going to be absolutely enormous. Now, to that point that I alluded to with nutrition, the best evidence we have in terms of effective treatments for insulin resistance to date are actually nutritional. And the problem is there's various diets that have been shown to be effective, and they're all quite different. So we've got caloric restriction, low carb diets, ketogenic diets, Paleolithic diets, and even whole food plant-based diets. Although when I went looking for the evidence for that today, I have to say that's more associational than experimental, and probably on a lower tier. But notwithstanding, certainly for some people who go on a whole foods plant-based diet, it is likely they may see some improvements in insulin resistance. Now, the problem with our understanding, our current understanding of insulin resistance, is that we don't have an understanding. Nobody really knows what causes it. And if we were to have a biologically plausible, evidence-based, mechanistic understanding of insulin resistance, then we would be able to refine and simplify the nutritional advice that we give to people. We wouldn't have to be saying, oh, we do a Mediterranean this or a low carb that or a carnivore, you know, what have you. It's sort of like a mechanic. You know, if a car comes in and there's a noise under the bonnet, you know, sometimes they can get a bit of an idea of what's going on. You know, you might have a squealing fan belt or a hissing radiator, but if you've got a knocking engine, you know, is that a piston? Are you just using the wrong fuel? Or if your bearing's gone, if you've got a problem with the spark plug? So, you know, you only get so much information from randomized controlled trials and experimental trials where you actually lack a mechanistic understanding. So the mechanistic understanding, in my view, is absolutely essential. So if we have a look at, you know, let's logically think about insulin resistance for a moment. And what do we know logically about what it is? And I have to say, I was having these thoughts almost 12 months ago when I was in a caravan, a motorhome actually, traveling around regional Queensland. And I was just pondering life, and insulin resistance came to that. And that's how I actually developed this theory of what actually causes insulin resistance. And it's very clear that when we have insulin resistance, it must be a receptor problem. It's not a problem with the insulin itself. So very occasionally, you can have antibodies against insulin, and then you use a different type of insulin, and that will overcome that source of resistance. But for the most part, insulin is working perfectly. It has to be a problem at the receptor level or downstream of the receptor. So that much is pretty obvious. But let's have a look at what the popular theories are on insulin resistance. And despite what people say, and there are some even high-profile people within the low-carb community who are quite strongly promote particular theories, I have to say they are lacking evidence for the most part. So the most common one, and one that I used to subscribe to, and is hyperinsulinemia. The concept that you've just got sustained high levels of insulin, and that somehow leads to downregulation or downregulates the sensitivity of insulin receptors. The other most common theory that's spouted is one of inflammation. One that, higher levels of inflammation or even chronic low levels of inflammation somehow drive insulin resistance. And most of this theory is borne out by associational research, where we see that people who are insulin resistant also happen to be inflamed. But, that's a case of the chicken or the egg, and again, mistaking causation and association. Now, there is one elegant study which I believe completely disproves both hyperinsulinemia and inflammation as being a potential cause for insulin resistance. And that was a study on pediatric burns patients. So we all know that burns patients are incredibly highly inflamed. They've got more cytokines flying around the systems than most any other disease, perhaps, short of a systemic inflammatory response syndrome or something like that. And the other thing about burns patients is that they have terrible trouble with glycemic control. All these stress hormones flying around, cortisol, with this gluconeogenic impulse that causes terrible problems. So these are notoriously difficult patients to manage. So in this population of burns patients, they were infused with supraphysiological, very, very high levels of insulin in an attempt to control their glucose levels. And in this state, this milieu of incredibly high inflammation and very, very high of infused insulin levels, their insulin resistance actually improved. So, you could call this a black swan or what have you, but really this speaks to the question as to, well, if it's not inflammation and it's not hyperinsulinemia, then what is it? And I believe the closest to the truth or the root of the problem that we're getting in the existing theories is something called lipotoxicity. Now, lipotoxicity as a phrase was coined back in 1990, and I believe it's close to the truth, but what it does, the theory of lipotoxicity lacks a mechanistic explanation, and that's what I'm going to try and put in today. But the lipotoxicity basically says that certain lipids, things like ceramides, which is a waxy fat that can be produced by the liver, or trans fatty acids, we've all heard of those, these fats can induce insulin resistance. And this is supported by some experimental evidence, albeit we don't actually know the mechanism by which these the ceramides or the trans fatty acids cause insulin resistance. We just sort of assume that we increase this and it does, insulin resistance results. Now, if we talk about ceramides for a minute, then this is particularly useful because it comes back to nutritional factors. So carbohydrates, especially fructose, ethanol, alcohol, and branched chain amino acids. These particular nutrients have one thing in common. They're all metabolized by the liver. Well, two things in common. The other thing they have in common is that they've all been shown to induce insulin resistance when consumed to excess. So you've got these three factors. So carbohydrates, ethanol, and branched chain amino acids, plus trans fats. So there's 4 known nutritional factors that can induce insulin resistance. So, well, I've just said that, but what is the evidence that ceramides and trans fats can do this? Well, first of all, let's have a look at what ceramides are. So they're basically a combination of 2 substances, a fatty acid and a molecule called sphingosphene. Now, the fatty acid is what's really important because these are saturated fatty acids and they're of various chain lengths. And the fatty acid in the ceramide that is most likely to cause insulin resistance, that's been most strongly associated with insulin resistance, is palmitate or palmitic acid. Now, anybody who's been around the low carb field for a long time will know that serum levels of palmitic acid or palmitate have been strongly associated with insulin resistance to the point of causality. And this association is one of the main arguments used against people consuming saturated fats. They said, well, you're consuming palmitate, high levels of palmitate in the blood, are so strongly associated with insulin resistance, it's almost likely to be causal. Well, here's the thing. Excess consumption of carbohydrates, ethanol, branched-chain amino acids, they all increase palmitate synthesis. So, and when we've actually done studies comparing high carbohydrate diets to high saturated fat diets, so diets high in palmitate, and the high carbohydrate diet actually leads to a much higher level of serum palmitate than does the diet high in saturated fat itself. And that's a really crucial point, because for too long, we've unfairly vilified saturated fats as being a problem. And this serum palmitate level has been one of the major reasons. And this also explains the linkage, the association between serum palmitate levels and insulin resistance. It's not the serum palmitate itself, it's the fact that it can turn into a ceramide palmitate. Now, ceramides were first suggested as an agent that could cause insulin resistance way back in 1990. And that was when this particular chemical was found in the livers and muscle of diabetic rats. And over the years, there's been ongoing research, and the research was considered so compelling that by 2005, two researchers, Summers and Nelson, claimed there was enough evidence to suggest that ceramides were causally associated with insulin resistance. And then this research got stronger and stronger. In 2007, there was a study where we know that giving people dexamethasone can induce insulin resistance, and that appears to be through gluconeogenesis, leading to the production of ceramides. So there's this drug called myriacin, where they gave that to rats who were also on dexamethasone therapy, and they're finding that this inhibition of ceramide synthesis blocked the development of insulin resistance. And there's been several other drugs, without going through them in detail, that have all shown the same effect. If we can block the synthesis of ceramides, we can block the induction of insulin resistance through particular insults. Now, coming back to the dietary component, we've got randomized controlled trial evidence that high fructose diets, high fruit diets containing fructose, cause insulin resistance. We've got studies showing that when we remove fructose from the diet, because fructose, in terms of carbohydrates, remember, fructose is predominantly metabolized by the liver. You've got a blower valve, if you will, with glucose. It can be stored in glycogen, so on and so forth. It has other pathways, but fructose doesn't have any of that. Whatever fructose you consume effectively has to be dealt with by the liver. That's why fructose is particularly prone to causing insulin resistance. So this palmitate, well, I should just talk about the biochemistry of palmitate production. So if you increase your acetyl-CoA levels too much, then you'll increase your pyruvate levels, and the pyruvate then will basically feed into this pathway called de novo lipogenesis. And de novo lipogenesis is basically making fat from carbohydrate or whatever other energy source you want. And the most common fat produced with de novo lipogenesis is its palmitate, this palmitic acid. So in studies where in 2017, a beautiful study, they removed fructose from the diet of these, obese adolescent patients, but they maintained their overall caloric intake and their overall carbohydrate intake. And within only 9 days, they had significant improvements in insulin resistance. And this has been shown numerous times. And then we have medications like metformin. So metformin actually inhibits the production of palmitate. So that's almost certainly the inhibition of palmitate leads to a reduction in the level of ceramide palmitate, which then is why metformin is beneficial in terms of insulin resistance. But then we still haven't talked about, we've talked about, okay, we've got evidence that ceramides do cause insulin resistance, but what's the actual mechanism by which they do it? And it's through something called a lipid raft. And this is really the crux of this talk tonight. So lipid rafts are something that most of you have probably never heard of. And we only know about it because of advancements in our understanding of cell biology. And while they are now, I believe there's, indisputable evidence that they exist, there is still some debate in the far reaches of academia. And part of this, I believe, is that because they're beyond the resolution of light microscopy. So it's been a long journey before we've actually been able to prove that they exist. So these lipid rafts were discovered, in the 1980s. And in 1987, they actually discovered insulin receptors sitting within lipid rafts in the fat cells of rodents. So remember, we just talked earlier that logically speaking, insulin resistance has to be a problem with the receptor or downstream of the receptor. So it's not a problem with the insulin or anything else. So we've now got an insulin receptor sitting in something called a lipid raft. So the lipid raft is basically like a lake that floats within the phospholipid bilayer. So we've previously been taught, all of us in our biology training to date, have been taught about the phospholipid bilayer and that it's this homogeneous layer that goes around the cell. In actual fact, spotted within this phospholipid bilayer, we have special other lakes that of different compositions called lipid rafts. And within those lipid rafts are housed insulin receptors. They're not housed outside of that. And if you damage the lipid raft, you can damage the insulin receptor. Now, and there's numerous components, not just the insulin receptors, but numerous components of the insulin signaling pathway has also been found to be housed within the rafts. And interestingly, when we talk about the composition of the lipid rafts, I alluded to them having a slightly different composition. Well, one of the major differences is cholesterol. The cholesterol concentration of the lipid raft is actually 3 to 5 times greater than in the surrounding phospholipid bilayer. So, and it's actually been demonstrated numerous times that depletion of cholesterol from the lipid raft actually causally leads to insulin resistance. And this perhaps also explains why cholesterol lowering medications, and it's not just statins, but it does absolutely include statins, is associated causally with insulin resistance. Now, it's not just the insulin receptor protein that lipid rafts are associated with. The lipid rafts are also associated with numerous immune receptor proteins, basically proteins associated with immune function. And I believe that this explains the strong association between immune suppression and insulin resistance. All of us clinicians who have seen diabetic patients, we know they're very, very vulnerable to infection. Now, there's another, these lipid rafts are very highly concentrated on specific cells as well. They're concentrated on kidney cells and cardiomyocytes, heart cells. And I believe that this explains what's recently been described as cardiorenal metabolic syndrome. The fact that we have such a strong association between heart disease, kidney disease, and metabolic disease, I think is adequately explained by the fact that tissues that are involved in each of those 3 pathologies are all highly enriched with lipid rafts. Now, this is just as a bit of a random musing, but dopamine receptors, as I said, it's not just insulin receptors inside lipid rafts, but dopamine receptors are also housed in lipid rafts itself. And I suspect that this has some explanatory value when it comes to understanding the food cravings and the mood disturbance that we tend to see in association with insulin resistance. So, for example, and I look at this through an evolutionary lens, is that I think as humans, essentially we're animals, and our very survival as a species depends on dopamine signaling, effective dopamine signaling. So what do I mean by that? Well, there's 2 behaviors that are necessary for the survival of the human race, indeed any race. That's procreation and eating. And both of those behaviors are driven by the release of dopamine into the mesolimbic pathway. So if we think about it, you're not getting up out of a nice warm cave to go and find food if there's not a strong drive for you to do that. And the release of dopamine is essentially very rewarding. It's what we chase. Now, imagine for a second that your lipid rafts have become dysfunctional, and I'll explain how that can happen. But ceramides is absolutely, definitely a cause of a dysfunctional lipid raft, and your dopamine receptors are not working as well. So in effect, you're normally existing here with dopamine, and now suddenly you're down here. The signaling's just impaired. And physiologically, you're hardwired to chase dopamine through the actions of procreation and feeding. So that sort of leaves us in a state where we're trying to chase it. Now, how do we get dopamine? How do we squirt dopamine into the mesolimbic pathway in a modern society? Well, now we've got these scientifically crafted foods, targeting the bliss point, so on and so forth. So we've got addictive foods. Some people might resort to alcohol, some people might resort to drugs, what have you. But essentially, when we have these dysfunctional dopamine receptors, we're going to be driven to, binging, cravings. Basically, what we're treating is a neurochemical deficiency. A neurotransmitter deficiency is basically what food cravings are. Now, I alluded to there being multiple substances and medications before that have the potential to impact on lipid rafts, and that includes GLP-1 agonists. I mentioned myriacin before. That was the first study in 2007 by which they found that inhibition of ceramide production could impair or basically prevent the development of insulin resistance. Fenretinide is another substance that's been studied by Professor Benjamin Bickman. Even sulforaphane, which we've all heard Rhonda Patrick talk about, inositol. This is, interestingly, clinicians are probably familiar with the use of inositol as a treatment for polycystic ovarian syndrome, by which we assume that insulin resistance is basically just a part of polycystic ovarian syndrome. So inositol also impacts on the lipid raft. Statins, lower cholesterol, induces insulin resistance. Philippin reduces cholesterol, also induces insulin resistance. Other medications, we know corticosteroids, well, that increases sugar production. Sugar production, de novo lipogen, that drives all the ceramide production. Antipsychotic medications have been proven, one, to cause metabolic disturbance, and two, they've been proven to have an effect through the lipid raft. So it's all very interesting. So essentially what happens is that when we produce these ceramides, these waxy lipids, they are incorporated into the lipid raft. So we can disturb the lipid raft through several ways. We can remove the cholesterol from it, or we can insert other waxy lipids that displace and basically disturb the structure. Now, the lipid raft is normally incredibly closely packed. Remember, it's got 3 to 5 times more cholesterol than the surrounding phospholipid bilayer. So any disturbance of the structure also disturbs the function. And trans fatty acids also does the same thing. So trans fatty acids is basically acts like a ceramide. So it basically incorporates. We know that these fats, when you ingest them, they go into the cell membranes, into the lipid rafts. Now, the interesting thing about trans fatty acid, I mean, it does get a little bit more complex, the story, but there are some types of trans fat acids that are not able to be metabolized properly by mitochondria. Now, this is interesting because that's theoretically the reason why they're quite appealing for use in food, because if they can't be properly metabolized, then they're more resistant to bacterial degradation as well, because you'll remember that the mitochondria share an evolutionary link with bacteria. So that's certainly been hypothesized as one of the reasons why trans fat foods appear to keep very well. But interestingly, there's different flavors, different isomers of trans fats. And the trans fats for industrial trans fats in particular have a flavor with a particular carbon number. There's a difference between carbon 9 and carbon 11 of the trans fats between ruminant trans fats and industrial trans fats. But here's the thing, that when you feed ruminant animals cereal-based food concentrates, the ratios of the trans fats that are produced, ruminant trans fats, actually changes towards that of industrial trans fats. So when we're talking about ruminant trans fats being fine and industrial trans fats not being fine, That's only true insofar as you're having pasture-fed ruminant animals, which I find quite interesting. But notwithstanding the connection between trans fatty acids and insulin resistance, I was quite surprised to find out is actually through lipid raft disturbance. Now, there's another feature that we haven't actually yet talked about, and that's phytosterols, which is basically a plant-based analog to mammalian cholesterol. And typically we only absorb these in very small quantities, but they do get absorbed. And when they get absorbed, they do get incorporated into our cell membranes. And that likely, now I haven't been able to find definitive evidence that it goes to the lipid raft, but there is definitive evidence that they do go into the cell membranes. And I postulate that it's likely that they do go into the lipid raft and disturb the lipid raft. Now, in terms of evidence for the ability of phytosterols to actually cause insulin resistance, I like to go back to 1965 to the rose corn oil study, which Nina Teicholz first told me about. And this was a randomized controlled trial where subjects were given either corn oil, olive oil, or a control group. And I actually quite like reading the old papers because they didn't have the word limits we have nowadays, and they could give you a lot more or of narrative description about it. And they describe that 2 patients who were removed from the study because they developed diabetes when they were fed corn oil. So in the first patient, he developed glycosuria. Basically, he began urinating out glucose, which is a symptom, as we all know, of poorly controlled diabetes. And then they stopped the corn oil and the glycosuria disappeared. So they said, okay, he's fine. So they started the corn oil again and it came back. It was like, okay, well, this isn't great. And then in the other patient, they gave the subjects glucose tolerance tests, and they found that while he was on the corn oil, he basically became diabetic as per the glucose tolerance test. And when he stopped it, then the diabetes went away. So this was actually the first, when I read this study, this was when I first had a strong visibility that these seed oils can actually cause insulin resistance and potentially diabetes. Interestingly so, there is a spectrum of phytosterols, this fake plant cholesterol, within seed oils. And rice bran oil is way up there, and corn oil is the second highest concentrations of phytosterols within. So in terms of then, if we put this together, so we've got certain foodstuffs that we understand the lipid raft is essential for the function of the insulin receptor. Disturbance of the lipid raft is a problem. That primarily occurs for the point of lipotoxicity, but while that's traditionally been described as ceramides and to a lesser degree trans fatty acids, I think we can also add phytosterols to that mix, and that should be a part of that conversation. And then when it comes to ceramides, we need to understand that while that's an agent in lipotoxicity, there's also nutritional factors that impact that, including as we said, the carbohydrates, the fructose, the ethanol, the branched chain amino acids. Add to that foods with trans fatty acids, which will either be cereal-fed ruminant animals or industrial trans fatty acids. And we've got quite I think, a compelling story of the factors, the elements of diet that we should be avoiding if we're wishing to preserve our insulin sensitivity. And fortunately, it's not just preserving insulin sensitivity. We have got some strong evidence of the ability to reverse insulin resistance with the elimination of these factors from our diet. Now, just for it's about 8 o'clock, so I probably shouldn't tattle on for too much longer, but I gave a lecture last year on concussion. This hasn't gone online yet. That was at an orthopedic conference. And I was absolutely fascinated with the evidence that concussion leads to insulin resistance in the brain, and also that is directly affected by the lipid raft. So you see there's these proteins that help stabilize the insulin receptor within the lipid raft. And this protein that stabilizes the insulin receptor is an accepted biomarker for concussion, for concussive injury. So you get a concussion if you disturb the lipid raft, you bang it up, you release this chemical into the blood. It's like when we diagnose rhabdomyolysis because somebody's got elevated creatine kinase levels in the blood. We can actually, when things are in the serum that shouldn't be in the serum, it tells us that there may be damage to the cells or the areas of the cells from which they originate. So in my studies, they drop weights on the head of mice, and they can actually, using electron microscopy after they euthanize the mice, they can actually demonstrate that they've got damage to the lipid raft, and that correlates with this elevation of these insulin receptor binding proteins in the blood. I find that absolutely fascinating, and so there's another mechanism that can cause insulin resistance. So I thought about this, and I thought, well, theoretically, then if somebody's involved in a car accident or a major trauma, then they should actually have whole body insulin resistance. That only makes sense. They would be having equivalent G-forces throughout their whole body as what you get with a concussion. And indeed, I found some historic research that probably couldn't be repeated today, where they actually demonstrated in motor vehicle accident victims significant insulin resistance when they gave glucose infusions and so on and so forth, and stuff that is probably frankly inappropriate in a critically ill patient. But again, it comes back to the point that trauma is also now, I believe, has definitively been shown to induce insulin resistance by way of lipid raft disturbance. So I probably should leave that there for questions.
Thanks so much, Paul. That was fantastic as usual, and definitely some new concepts for people to take in. So we'll open up the floor for some questions. But before everyone else gets in, I guess just to sort of ask you off the bat, what would you like to see done next? Like, what's the experiment you would like to see done, or what's the research that you think naturally follows on from this that would help us as clinicians?
I think there's two. I think we need some of those, the randomized controlled trials, which I think can approximate the truth, but that they can help us with the interventions and proving the interventions work. But I think I'd like to see some more mechanistic research. For example, there's people out there with labs who can do research on, do phytosterols from seed oils incorporated into the lipid raft, not just the membrane, but the lipid raft component of the membrane. So I think there's several directions for baseline biological research that could be taken in labs. And then obviously the case is, well, if this understanding is correct, so all of these, the commonalities in the diets that we talk about, ketogenic, low carb, Paleolithic, so on and so forth, is the commonality that we're reducing fructose, is the one commonality that we've eliminated trans fatty acids. Certainly with ketogenic and Paleolithic diets, the diets that have the strongest research, there's a increasing emphasis on reducing seed oil consumption. So it would be nice if we could then simplify and refine our dietary recommendations, which would make it much easier to roll out on a widespread scale. And the reality is our food systems are not set up for everybody to consume a healthy diet. As it is, most of the food we produce is unhealthy food. So if we want to transition a population to a healthy diet, we need to try and make the recommendations as simple and refined as possible, because to try and minimize the disruption to the food industry. So my ideal dream would be that this concept is understood, that people appreciate, yes, this is what it is. And then we do focused lab, bench research to prove it, randomized control research to prove the benefits of the effect. And then hopefully we get enough political influence that we can start changing public health guidance, that the Australian Dietary Guidelines could actually, reflect the science.
Yep. Great. All right. So anyone else who's got a question, if you could just raise your hand and we'll take them one by one as they come. Nobody. I find it hard to
That's a bit ominous.
Well, I will keep talking, but I'm mindful that I get to badger Paul with questions every time we catch up for dinner.
Liz has a question.
Liz?
So I was reading about fatty liver disease recently, and I came across a reference to fructose, and you mentioned fructose is predominantly metabolized in the liver. And this article said that most fructose is metabolized by the small intestine, but, quote, fructose induces lipogenesis when its dietary intake exceeds the intestinal clearance capacity. And that got me thinking that some individuals may be more prone to fructose-induced liver fat accumulation. And I'm just thinking aloud here, but FODMAPs is fructose, oligodimonosaccharide.
I've had the exact same thoughts. So
Great minds.
Here's what we know. Before I sort of had my conversion to low carb, we're dealing with athletes. The goal is to try and get as much carbohydrate into them as possible. So we used to play around and say, well, you can absorb X grams of glucose an hour, and you can absorb X grams of fructose an hour. And that's approximately 50% less fructose can be absorbed than glucose I haven't looked at the research in depth, but that's generally considered to be the basis. Absolutely correct that there is some intestinal metabolism of fructose. To say that fructose is predominantly metabolized in the small intestine, I don't know if that is true. Potentially, but what we do know is that we see metabolic disease at a far higher rate in people with inflammatory bowel disease. And I hypothesize that this is purely due to their reduced capacity for intestinal fructose processing that does end up leading to a bigger load having to be dealt with by the liver. And so we do see when we put people on elimination diets, it's nothing to do with carbohydrate reduction. It's purely just due to gut health and trying to improve the function of their intestine, that we do see these improvements in metrics associated with metabolic health. So I believe that to be the main linkage between metabolic disease and inflammatory bowel disease.
I guess I was thinking of irritable bowel syndrome rather than inflammatory bowel disease, and FODMAPs is associated
Well, the whole thing about irritable bowel syndrome is it suggests there's non-digestion of a particular nutrient, and causes problems because you have bacterial fermentation of whatever's not been digested. So if it was as it's been described, irritable bowel syndrome, then the fructose is not absorbed, so it's not going to be having an impact, except for the fact that you then produce a methane and you get this combined effect of constipation and diarrhea because the methane inhibits peristalsis and the fructose itself has an osmotic activity that draws fluid into it and all that, and that's all pretty ordinary. But I think, if you look at it mechanistically, the fact that by definition, irritable bowel syndrome means that the fructose is not absorbed, it's not going to be having a significant metabolic impact. Now, I personally believe that what is frequently diagnosed as irritable bowel syndrome is frequently undiagnosed inflammatory bowel disease. And I won't bore you with details on that, but I think that happens more often than not.
Okay, food for thought. Thank you.
Well, we've just got a question in the chat. Just wondering if you think people who can't afford grass-fed meat are better off eating grain-fed, or should they avoid meat due to the trans fats?
I think the meat, it's hard to beat meat, and the degree of trans fats in Australia. So in Australia, even if you're having grain-fed meat, it's going to be grain-finished. It's not going to have been grain-fed the whole life. So that's going to be quite different to some of the studies I was reading, looking at feedlots out of Europe in the winter and in the US. So I think in Australia we're in a fairly privileged position, and I would still go grain-fed meat.
Cool. We're pretty lucky in Australia, aren't we?
And a lot of, I've heard stories about some of the brands, the cheaper brands of meat, like coming from Tassie, they've just had excess that they haven't been able to offload. So they've just sold some of it to the supermarket. So there's been some very lucky customers out there buying supermarket meat and getting top shelf.
That's good to me.
Doesn't happen often, I'm sure.
I'm not sure the farmers want it to happen not that often either. while we're waiting for other questions, I'll put another one to you, Paul. It's quite common for us to see patients who have been on ketogenic diets for a long time who have what some people describe as physiological insulin resistance, or I guess the classic case of you take someone who's been on a low carb diet for a long time and they fail their glucose tolerance test, or they get an exaggerated response to it. Do you think the lipid raft theory has anything to offer patients in terms of insight on that front?
I mean, that's an impossible question to answer because we don't know where these patients started from. We don't know what other factors are going on. So, you know, we do see people who come in, and one point that I didn't make at the start is that it's commonly assumed that insulin resistance is associated with hyperinsulinemia. Now, that is common, but it's not always the case. And I have heard people say that it is always the case. We've got an increasing epidemic of insulin resistance, and about 10 to 15% of patients who are diagnosed with type 2 diabetes actually have an autoimmune component. They've got a type 1 diabetic component, if you will, what we call LADA, latent autoimmune diabetes of adulthood. And what this means is that they end up with a relative insulin deficit. So they've actually got an autoimmune response where their immune system is attacking the beta islets secreting cells in the pancreas and creating a relative insulin resistance. So I consulted with a patient just today who had a fasting insulin of 6. And I said, well, that's fine, but I need to see what your glucose is, because that could be a good 6 or it could be a bad 6. And when we went and saw the glucose, and he had, you know, elevated fasting glucose. And I said, well, look, you know, I would prefer your insulin be 10 and your glucose be normal, rather than your insulin be 6 and your glucose be abnormal. So he had a combination. He was a LADA patient. He had a combination of insulin resistance, because 6 isn't overly low, but it's healthy range. But the fact is that his insulin wasn't able to do the job tells me that he was also insulin resistant. So there are nuances to people like this, and I suspect some of the people we're seeing who are simply not responding as well to a low carb diet, they could be in that, you know, 10 or 15% of people who have LADA, and there's no amount of low carb diets that are going to control that. You know, if you have a deficient pancreas, you're going to need to inject with insulin, you know, once it gets too low. Now, I've seen some people who are just putting out tiny amounts of insulin, and they've been strict on low carbohydrate diets. And by doing so, they're able to avoid the need to inject insulin. But I can tell you, if they approached anything resembling a standard omnivorous diet or even a standard low carb diet, they would need to inject with insulin.
Yeah. Yeah, interesting. Cool. Just in the chat here, Prof. Roy Taylor says one should lose 15% of body weight to reverse insulin resistance. What do you think?
So he's talking about the association. When people tend to lose weight, yeah, sure, they tend to become more insulin sensitive. But what is the mechanism that's going on there? So he's ascribing causality to the fat mass itself, and that it's not the fat mass itself that is the problem. You can be insulin resistant and be skinny.
It sounds like it's describing a common scenario rather than the only scenario, I guess.
It's without a mechanistic understanding of the mechanism of insulin resistance.
Yep. Aman, you had a question?
Yeah. So knowing that statins affect lipid rafts by reducing cholesterol and causing insulin resistance, do other drugs such as, say, fibrates, which lower triglycerides and increase HDL, do they also affect lipid rafts in the same way, or could they be a good alternative to statins?
So I'm not going to necessarily accept that fibrates do actually, in all research, I wouldn't necessarily say they absolutely do lower triglycerides and increase HDL. In terms of fibrates, I haven't specifically looked at their impact on the lipid raft, but that is something that I can easily do. So whether I can give you an answer today or not might be a moot point.
Yeah, thank you.
I don't know how to put up my hand, but can I ask a question?
Oh yeah, don't worry about hands. There's too much
Hi,
silence
Paul. How
going
are
on.
you? I was late, so I probably missed the exciting bit. But I always watch Ben Bickman videos, and he has that lovely clear way of explaining the 3 causes of insulin resistance. And he always mentions hyperinsulinemia as, you know, recurrent eating of carbohydrates causing insulin to rise
Yeah.
as his thought as the major driver. So how does that affect the lipid raft? How does that work with?
Well, I'm guilty of promoting that myself. And, you know, we give various analogies saying, oh, it's just like your sense of smell. If you smell something, you get used to it. The insulin receptors downregulate sensitivity. I actually did refer to a pediatric study on burns patients who had very high inflammation levels. And because of their very high glycemic levels, they were actually infused with ridiculous amounts of insulin. And they found that when they infused them with high levels of insulin, their insulin resistance actually got better, not worse. So they were very inflamed, supraphysiological levels of insulin. So that was an elegant study for me that actually, you know, had me questioning, saying, well, maybe I'm wrong. That can't be true. So, and that's one of the stimulus for me to go and look at this. So, yeah, I mean, so I've actually, you know, I've written 2 papers with Ben on different topics, but on this account, I know he's adamant that this is a cause of insulin resistance, and I'm going to have a hard conversation with him.
Okay.
Paul, in the chat, there's another question. Do the LADAs always have IA2 and GAD antibodies?
No. So, and this is an interesting thing. It's just in the same way that, you know, various autoimmune diseases, you know, the antibodies don't always talk to us because there's potentially hundreds of different epigenetic targets. So in terms of the best way to diagnose it, I believe it's the Kraft test, where we give people a shot of glucose and we measure their insulin and their glucose levels over a period of time. And if at any point you see, you know, you should be used to, if we've got a type 2 diabetic who's insulin resistant, we're expecting to see higher levels of insulin. And if at any point we see what could be called a normal level of insulin with a high level of glucose, and that tells us it's a failure of insulin secretion. Because people with a working pancreas who are just insulin resistant, they can pump out, you know, they might have 200, you know, for their insulin. You know, I've even seen it up to 500 in some individuals. But so, yes, antibodies is a less reliable way. The problem with the antibodies is that we need it under our, you know, the government requirements to be given subsidized CGMs.
Yep.
So without the antibodies, you might have an autoimmune diabetes. And I've got multiple patients who, you know, have been, I usually use Soji Swaraj as my preferred endocrinologist. He says, they've absolutely got it. You know, they're not secreting any insulin at all. They're way down, but they can't get the CGMs because they are antibody negative. So it's quite common.
Yeah. Got a few patients in that situation are quite annoyed by the rules, but yeah, it is what it is. It's unfortunate at the moment. Just another question in the chat. One of the trends here in the UK is the use of Wegovy, which is a GLP-1 inhibitor available on open market, so on Amazon. Do you have any insights on this trend?
I mean, this is the
What could go
biggest
wrong?
scam forever. I mean, seriously. Okay, let's have a look at it. Okay, good amount of weight loss. Quite possibly superior to what you get on ketogenic diets. And probably only about a third of that weight loss is muscle or bone. Okay, but that can't be good. The longer you're on it, presumably the more muscle and bone that you're losing. Now, here's the interesting thing. So this study that actually, they did a large randomized control trial. So these patients lost weight, and if you go to the supplementary data, you can actually have a look where they provided the breakdown for where the weight came from. And you can see, okay, they're losing an extraordinary amount of bone and muscle in an elderly population, which they may never get back. We don't know. And then they did a follow-up study of what happens when you stop it after 12 months. So they regained 60 or 70% of their weight, but they didn't provide a breakdown on what weight that was regained. And this was a drug-funded trial, which made it quite surprising that they even had that data available in the first place in the appendices. You had to download the supplementary data to actually get to it. and they didn't provide it in the follow-up. So one could maybe presume that the weight they regained was simply the original fat that they'd lost, and that they'd been left with a deficit of muscle and bone. So the consequences of using this drug basically led them to be at incredible risk for osteoporosis and sarcopenia. And I suspect that we're going to see the consequences of this in coming decades, where people have been, severely damaged. There's also been some interesting aspects on lipodystrophy. We know that people on retroviral therapy for HIV, for example, have very interesting fat distribution patterns. They sort of get fat in all the wrong places, if you will. And there's certainly some suggestions that that's occurring on the people on the GLP-1 agonists as well. And that's quite preliminary, but I think that's going to be a major problem in the future.
Ron?
Right. Thanks, Paul. Going back to those LADA patients and with the low, potentially low insulin, firstly, how useful is doing C-peptide? And secondly, in people who have this and they're low carb, then I think the Kraft response may be quite poor, because my understanding is the pancreas goes to sleep, and so they'll end up looking quite diabetic.
Well, fortunately, I wasn't aware that the pancreas was meant to go to sleep several years ago, probably 8 or 9 years ago, when I started doing the Kraft test. So I was a bit ignorant, so I'd do it anyway. And I was just seeing case after case of resolution of diabetes. And I wasn't giving people any advice to carbohydrate load. I was specifically, they'd ask me, I say, why on God's green earth would you do that? Carbs are bad for you. You're diabetic. Don't do that. And still, I've got hundreds of documented cases of remission of diabetes when they do not consume carbohydrates. They don't carb load. So this whole concept about the pancreas going to sleep is, I think, just nonsense. And it's very easy to prove that it's nonsense, because you also have an insulinogenic effect when you consume protein. And these people, so in type 1 diabetics, we're saying, okay, dose this for your carbs, dose half the amount for the protein. So these people are still working their pancreas. They're still having to release insulin when they're consuming the protein. So I think it's just implausible that, the pancreas would go to sleep. And I certainly see no evidence of that.
And the C-peptide?
I think C-peptide is useful in people who are injecting with insulin. I mean, because obviously what C-peptide does, it allows you to distinguish between exogenous and endogenous insulin. And for that, it's quite useful. Just another thing that is, I guess hijacking your question, because it's not what you asked, but I don't know if you've ever noticed that some subjects have reactive hypoglycemia within a Kraft test. And I haven't been able to find any substantive literature on the definitive cause of it, but thinking about it, the thing that makes most sense to me is a glucagon deficiency from damage to the alpha cells in the pancreas. So we always talk about the beta islet cells because they secrete the insulin, but mixed in with them, you've got these alpha cells that are secreting glucagon. And I often suspect that when we see this hypoglycemia, that one of the causes of that is probably alpha cell damage, and you end up with a glucagon deficiency, and you end up with a substandard counter-regulatory response to the insulin. Where we've had a bit of insulin now, we need to release a bit of glucagon to bring it up, and that response has essentially failed. So I'm now, in a couple of my patients, I'm starting to do glucagon levels within the Kraft test as well.
Is that on the PBS? Is that on the...
I'm afraid not.
How much is it?
I don't even know. I think it's about $50. I couldn't tell you precisely.
Okay.
I'm really showing my shortcomings as a financially prudent physician here, aren't I?
Patients happy to pay, I guess.
Well, I mean, if you get an answer.
Liz, did you have a question? No?
You're muted, Liz.
Hang on, I can lip read.
Getting back to LARDAs and C-peptide. I've seen a chap who's a 67-year-old, very keen athlete, does 3 hours of exercise a day, has been keto for about 6 years, came to me as a new patient within the last few months. And his fasting glucose was a little bit elevated. His HbA1c was higher than expected, I think about 5.8 or 5.9. And he had a C-peptide of 2 and negative antibodies. And one of his concerns is that he...
So when you say a C-peptide of 2, so the range
Oh, sorry,
is at
point
0.2, so half
2.
the lower reference.
Yeah, well below the normal
okay.
reference range. And I thought about LARDA, but the antibodies were negative. And now
Almost
that
certainly that is LARDA, almost certainly. So, I mean, as you know, okay, we can often see a C-peptide of 0.4 in healthy people with normal glucose. But if I'm seeing a 0.2 in somebody with hyperglycemia, then that's absolute proof of an insulin secretion deficit.
Right. I've got him using a CGM at the moment, and his blood glucose actually looks pretty good. One of the things we were concerned by is he's got retinitis pigmentosa and he's losing vision, and he says he gets quite stressed when he rides a bike by himself. And it's early days, so we're trying to work out what's going on. What should I be looking for on the CGM?
Well, first of all, let's have a think about retinitis pigmentosa. So if you actually have a look at the literature, which I did a couple of years ago, the damage is largely oxidative. And we know that fluctuating glucose levels leads to mitochondrial generation of reactive oxygen species. So for him, he would absolutely be well advised to keep pancake flat CGM. Now, if he needs to have a lick of insulin to do that, then that's quite reasonable. So assuming if you do a craft test with C-peptide and or insulins, and you see that he's got some insulin secreting capacity, then that's good, because what you can do is you might give him a long-acting insulin basally. And sometimes what we do, we start with pediatric syringes, so we can dose it half a unit at a time. We don't have to go the whole unit. So just a basal, and then hopefully his secretion capacity can just give little boluses as he needs to control that. But so just basal. So you want strict control. I've also had good success in patients with rapidly deteriorating vision. It's an awful condition. And we've been able to basically plateau and even get some improvements. So they're basically hitting everything at it. And one of those features was high dose antioxidants. So things like N-acetylcysteine, coenzyme Q10, glutathione. I was just throw everything at it in terms of, and they've got the macular degeneration supplements, which are, usually have vitamin A and so on and so forth. And they have mechanisms which are often antioxidant as well. But I would be emphasizing the fact that unstable blood sugars are likely to worsen the eyesight, and doing everything you can to get control of oxidation stress. And just as an aside, one thing that we do know is associated with it is hemochromatosis carrier state. Now, for some reason, we don't tend to diagnose hemochromatosis unless we can find a positive gene, and we usually only test for 2, the C282Y or the H63D. But the reality is there's numerous genes that can be involved, and in my mind, anybody with elevated ferritin is likely to, we say, well, effectively that's a hemochromatosis. Also bearing in mind that low folate can be a cause of elevated ferritin, and that's often underdiagnosed. Now, when you have a look at the blood tests, the reference interval for folate that says anything over 7 is adequate. I was looking at the literature this morning because I should have been actually preparing a talk for this, which I obviously didn't. I was looking at other things, sorry. But it was quite interesting. I was looking at the all-cause mortality data with respect to serum folate levels, and it looked like the lowest all-cause mortality was associated with serum folates in the order of 50 to 60, which is way above the 7 which we accept. So given that all of these, yeah, I've probably sidetracked a little bit, but focus on sources of oxidation stress, maybe check for hemochromatosis, make sure the folate is super high, a bunch of other antioxidant supplements, keep the insulin pancake flat. If you need to give them a lick of long-acting insulin through, half a unit or something like that, then do it.
Okay, thank you.
Thanks, Paul. What do you think about lack of sleep as a cause or a contributor to insulin resistance? Everyone terminates their sleep artificially with an alarm clock every day, and metabolic disease is ubiquitous.
Yeah, it's a huge cause. So we know the dawn phenomenon. There's also been some convincing research that shows that sleep deprivation actually induces the dawn phenomenon. The dawn phenomenon being this state of elevated glucose level when you're waking. Now, this is not, it's pretty obvious when you think about it, because we've got insulin that lowers glucose. And on the other hand, we've got several hormones. We've got your adrenaline, your growth hormone, your cortisol, which actually increase insulin, your gluconeogenic hormones, and your glucagon. So there's 4 of them that take it up. Now, cortisol has a strong diurnal variation. It's a stress hormone. I don't know if you got kids and you hear a cry in the middle of the night, somehow your radar's tuned in and you have that startle response and your heart goes. There's a huge amount of cortisol going. You're pumping out cortisol, and when you're sleep deprived, when you're waking up to an alarm, those your adrenaline, your cortisol, these hormones that are gluconeogenic, they're going for it. So absolutely, sleep deprivation's one of the worst things you can do that's potentially within your control that will make insulin resistance worse. Having said that, we alluded earlier, Liz, we were chatting about the intestinal metabolism of fructose and how that can potentially relate to insulin resistance and so on and so forth. Well, here's an interesting thing with sleep disturbance. Inflammatory bowel disease, as well as impairing your ability to metabolize fructose in the intestines, is associated with sleep disturbance, and I believe it's associated in a causal manner. About 75% of people with inflammatory bowel disease are diagnosed with pathological sleep disturbance when they're examined. When you survey people with inflammatory bowel disease, they've done these studies, what's the biggest problem you have with your disease? They don't say it's bleeding from the bowel or the pain or all these other terrible things from inflammatory bowel disease. They talk about the sleep disturbance. And that's and there's no amount of sleep hygiene, there's no amount of blue light filters that gets over that problem. And the way I think about it, that seems to be logical to me, it might not be logical, is that if you have a big drink of water right before bed, you're going to wake up in the middle of the night to pee. And the reason you'll wake up is because you'll have this visceral irritation, you'll have stretch of your bladder. So we seem to be sensitive to visceral stretch, visceral irritation as means of disturbing our sleep. And the whole gastrointestinal tract is our viscera. So if you've got inflammatory bowel disease, if you've got reflux, what have you, that is going to wake you up. And I think that that's the most likely causal mechanism. I haven't looked into it in detail, but that's just, a bit of brainstorming in my head. I think that's a plausible reason as to why people with inflammatory bowel disease are so susceptible to sleep disturbance. And that probably is also another causative factor in the association between these types of autoimmune diseases and metabolic disturbance.
Interesting. Probably got time for 2 more questions. So I know, Sanjeev, you got your hand up and we've got a question in the chat. So Sanjeev, did you want to go first?
Right. Yeah, thank you. Hi, Paul. This morning I saw a patient who's in his 20s, very fit, athletic, very healthy diet, 95% meat base. And so we did his metabolic workup return today. Very low ALT, gamma GT, triglycerides 0.4, HDL around 1.9, fairly good. But his fasting insulin was 2 and fasting glucose was 3. So with someone with this type of numbers, is there anything I should be worried about? Where the insulin levels are lower than the glucose?
So the glucose is still incredibly low. So that doesn't speak to me like a relative insulin deficiency. It speaks like an unusually low level of insulin. But he sounds like he's unusually insulin sensitive, he's got the phenotype of somebody who's particularly metabolically healthy. I mean, because the numbers though, and my radar always goes up when I see numbers outside of the norm of what I'm used to seeing, not the reference intervals, but what I'm used to seeing. And I'd have to say an insulin of 2, I generally, when I start seeing insulins of 2 and 3, I often routinely just do a craft test, if only for my peace of mind. And the other thing I do is a continuous glucose monitor, just to make sure that there's no funny business going on. And those results are anomalous enough. Now they're anomalous in a good direction, but they're still anomalous enough. Now, one thing that did strike me is that you said the triglycerides were 0.4. Now the HDL was fabulous, but also when I see triglycerides below 0.5, 0.5 is pretty much an optimal point. I have seen them as low as 0.3. And that was in a patient who we ended up diagnosing with malabsorption. And I still don't understand the mechanism of how that malabsorption impaired her ability to synthesize triglycerides. But just this combination of lower than typical triglycerides and lower than typical insulin and lower than typical glucose, that would have me doing further investigation simply on the basis of you described this patient to me, and I don't have a clear understanding in my head of what's going on with that patient from what you've just described. And when I get that degree of confusion, part of me wants to figure it out just from an academic perspective. But more importantly, it's like, well, we don't want to miss anything. So I would probably, at the very least, I would do a CGM, and I'd consider doing a craft test.
Sure. Thanks, Paul. Thanks so much.
All right, Paul, last question. How do you strike the balance between supplementing insulin as a fat storage hormone and trying to achieve fat loss to reduce insulin resistance?
I don't try and strike that balance. See, if you have a larder or something like that, one of the major ways I diagnose my larders is with people who are losing weight rapidly, or they're having trouble maintaining weight. So it's not really an issue. So I don't find myself with the need to give people insulin who are generally significantly overweight. Now, the person asking the question may actually have a patient who is deficient in insulin and still overweight, but I don't find that a common presentation. I mean, you see a lot of these patients too, Alex. We share a lot of the same patients. Is that a common clinical scenario that you see?
Not often. Everyone's
maybe. The person who's asked the question, if we can put them on the line, maybe there's a particular scenario, particular case example that they've got.
Hey, Paul. It was more of a like, I guess, a less of a exact example that I have, but more just a theory. Maybe I could have framed the question a bit better, but it was more just, is there a balance that needs to be struck? I guess.
Not really, no. I mean, honestly, I would always prioritize glycemic control over weight loss if I had to choose. So you can be fat and healthy, but you can't be diabetic and healthy.
Yeah, I think that's fair enough. Cool. All right. Well, I think that's all the questions, Paul. Thank you so much for your time. And thank you for everyone who's attended tonight and offered all those wonderful questions. I think that was a very stimulating discussion.
Thank you so much for having me, Alex.
No worries. Deepa? We'll have to have you back sometime. Just to let everyone know that the next month's monthly grand rounds will be from Dr. Peter Bruckner on Wednesday, the 26th of June, and he's going to be talking about the use of low carb for osteoarthritis and inflammatory arthritis and his experience on those topics. And we'll send out a link prior to the date for that as well. All right. Thanks so much, guys. Have a good evening.